Hello, everyone. My name is Kathy Bassett, and I am here to share some thoughts with you today about the use of computer-controlled local anesthesia devices. A little bit of information. This is where I am today. I am from Washington State, and we have rain as usual and a little bit of sun coming along the way. So why me? I've been working in dentistry for over 50 years and 40 years as a hygienist. And during that time, I've administered anesthesia for periodontal procedures, for restorative, oral surgery, and endodontics. I'm also a co-author of the textbook, Local Anesthesia for Dental Professionals. And for the last 30 years, I've been actively involved in teaching dental hygiene and dental students, CE courses for hygienists and dentists, educators, and others who participate in administering local anesthesia in the United States. It's conflict of interest. I have a variety of things involved in particularly authoring for articles and for a textbook. I regularly do continuing education courses that I've received some honorarium from. And then as a key opinion leader, I have relationships with Milestone Scientific and Directed Dental and Septodont USA talking about the use of computer-controlled local anesthesias. And I have received honorarium from all three of those companies during the past year in programs on that content. So I think it's always important that you can, walk your own talk. And so here's part of my collection. And just starting out, my father had been a dentist and he practiced until he was 78 years old. And the thing that really changed for him towards the end was it hurt his thumb to aspirate during injections, and he really hated electronic health records. So to solve the problem about the discomfort in his thumb, he got a Midwest comfort control syringe. So that was my first experience, both receiving anesthesia with a CCLAD and utilizing one. And I just really knew there was, something special about these devices. My next introduction is then I had an opportunity to get my hands on a CompuDent. Moved on to the next rendition of the CompuDent, which is what we commonly see available to us as the STA or wand. And then the CalaJet came along, and then most recently available to us in North America is the DentaPen. So over the course of the last 15 years in particular, I've been able to work with all of these devices. And then also I had a unique opportunity to be part of the FDA market research project when there was an attempt to bring the Quick Sleeper device to the United States. So here's where I want to talk about today. We're going to look at the CCLADs available in North America. I want to show you a few of the learning curves as you move into using these technologies. I'm going to contrast a little bit about the differences between manual and CCLAD devices. And then, hopefully you'll really be able to connect with the benefits for both the patients and for us as the clinicians, in particular in the area of ergonomics. And there's a unique pathway where the CCLADs are very advantageous to us as well. And then kind of look at how those devices can reduce those risk factors for us. So stepping back a little bit, we've been doing local anesthesia for dentistry since the 1800s. So dentists first formally had a relationship with anesthesia delivery starting in 1884. Cartridges were first available to us around 1921, and they have stayed essentially the same cartridges, that we use today. And then in 1971, here in Washington State, local anesthesia delivery by hygienists was brought into our Practice Act and started to be taught in the hygiene programs around the country. But if we go back into that circa 1940s, here's what some of those early syringes looked like. And so it's not that much different than a lot of the syringes we pull out of our drawers today. And I think this is a good place for us to start reflecting on what have we carried forward versus what is really available to us. So when we're doing anesthesia, keeping our eye on the target here, it's this very small region in those gaps between the nodes of Ron VA where the anesthetic actually gets into the nerve membrane. So when you really get down to the moment of success, It's choosing applications, devices, techniques, locations that really leverage our ability to comfortably get enough quantity of drug in the area of these nerve fibers. So here's what a lot of things, if we started opening up our cupboards across the country, this is what we're going to find. And to the left here, you see a lot of syringes that look a lot like that syringe that was circa 1940s. Then we also have, devices for delivering topicals, devices for periodontal ligament injections, and devices under jet injectors, and then, the beginning of bringing the CCLADs in. So my question to you is, how do you get your anesthesia done? One of the things that's important is, what we're really trying to do is we're targeting those nerve fibers is really be over here and be the good egg. Be way over here to the left, no pain or just minimum experience during that injection. But as we move to the right, we really want to avoid any of those sensations with our patients and them reporting back. This is extremely discomforting, distressing. Wow, that was really intense, or that was excruciating. And there are ways that we can do that and leverage technology to help us. So let me ask you, when you look at what you're using today, are you ready to explore some new technology? In 2015, there was an annual review of public health published, and this is what they said: worthwhile medical ideas that are backed with credible research take nearly 17 years to be integrated into routine practice. That reflects nearly half the length of the average career. And to put that in perspective, things that were brought to market, made available in 2015, still may not be integrated into practice. Here we are nearly 17 years later. This slow uptake of adoption is not benefiting patients. And again, this was credible research, worthwhile ideas, and we're not bringing it to the benefit of patients. Here's an article that was written by Dr. Jeff Parrish of Kirkland, Washington, and he attended a CE class that I gave at Pacific Dental Conference in Seattle a number of years ago. And then he wrote an editorial, and I asked if I could borrow this paragraph from him because I think it's so much told this story. And the title was, "Old Dogs Can Learn New Tricks, but Puppies Get Set in Their Ways Very Early On." So the question is, as an old dog, do we continue doing what we did, even when the evidence is overwhelming that there are other technologies that will improve our outcomes, improve patients' comfort, and we just stay with what's comfortable? We just don't really muster up the courage to try some new things. And then also, if we give it a try and go, oh, that didn't work, then we kind of revert back to our old ways. And I've seen this happen where people have bought devices, got them into the office, gave one attempt at it and went, oh, that didn't do what I thought. In the cupboard it went. And then again, that was a lost opportunity for the benefit of the patients and for the clinicians. One thing that we wanted to take a closer look at these puppies in this story. And so in 2011, we started a research project with our students here at Pierce College. And we did a side-by-side study, and we had half the students start from day one with conventional manual syringes. The other half of the students started from day one on CCLADs. And at the time, what we had available to us was the wand. So for the first 6 months, through their primary training and all opportunities to give injections, they were on a split design. What we were really looking at is, what's the implication if you introduce that technology at the very first stage before that sort of muscle memory and comfort comes into play? And we were really looking at questions of how confident were the users, how easy were the devices, and how comfortable was it to give and receive those injections. So we repeated this for 6 years with cohorts of 20 students. Each student gave and received 25 injections, and they had 4 different surveys they did for that experience. And again, we repeated this for 6 years. What we found significant from year to year was, from the clinician perspective, they tended to prefer the syringe they learned first. But when you flipped it to the patient experience, the majority preferred to receive the injection with a CCLAD. So we got stuck in what we learned first, but if we move to the position of comfort, the vast majority, greater than 87%, repeated that they wanted the injection with the CCLAD. So, what does this really mean? Again, we need to look at what we learned first. We learned it well. We learned it with great confidence, and then that kind of holds us back from advances. So computer technology in anesthesia for North America has been available since 1997. They use electronic mechanical motors. They're regulated by microprocessors to control the fluid dynamics of delivery. And there's extensive research globally. Benefits are when we control rates, we control pressures released into the tissues, we can calibrate reliable aspirations, and we can counter a lot of ergonomic disadvantage that's built into conventional syringes. Also, there's a unique outcome, as our study showed as well, of patient comfort. So the roll call of June 2022, these are the 3 devices that you could actually go and check out at your next dental convention and have in your office for practice. And they are the CalaJet, the DentaPen, the STA single tooth anesthesia system, which is also commonly known as the wand. So here's just, an example of where research has been done around the globe. And there's greater than 200 articles, again, echoing that same position that these are proven alternatives to manual syringes and repeatedly demonstrate patient comfort and ease of the clinician. One of the things that was looked on early in the research on computer-controlled devices is what we refer to as the tissue compliance and the fluid dynamics. So to answer those questions, what is tissue compliance, and why do we really care about controlling those fluid dynamics in real specific ranges? And so we can organize the types of tissues that we give injections into by 3 basic common types. Number 1 is what we refer to as type 1, which is the greatest adaptive capacity. They're really flexible. We can easily move, needle insertions into those spaces. Drug very easily is expressed into those spaces. And we can comfortably, at approximately 1 to 2 minutes per cartridge, deliver solution into those spaces. And it only takes us about maybe 9 to 12 PSI to actually release that solution. An area of a type 2 tissue that's lesser adaptive capacity, less flexibility, thinking again of our attached gingiva, palatal tissues. And now we're going to be moving a little bit slower for that solution to gently move into the space. Now we may be 1/3 of a cartridge to a half a cartridge a minute. And it's going to take about 50 PSI to 70 PSI to express that solution into those tissues. And then the most resistant is when we're doing periodontal ligament injections. And to move solution through those periodontal ligament space, it's going to be a much slower rate again at approximately 1/3 cartridge per minute. But the force needed to continue that deposition is going to be about 225 PSI to 350 PSI. And those are significantly less than the manual ratcheted style periodontal ligament syringes. So we're able to keep the pressure needed to deliver, but also at the same time have lesser pressure used to administer that. Because we need to continue that flow so that that solution can move down and then distribute through the cancellous bone, surround that tooth to get that profound single tooth anesthesia experience. Another way that we can deliver anesthetic so that it moves through the cancellous bone is an intraosseous. So this is just contrasting, what your position would be to deliver it via periodontal ligament injection versus deliver it via a intraosseous injection. When we look at flow rate, just think in terms of the words drip, burst, and stream. When we're going slow, and that's going to calibrate out to approximately 1 cartridge per minute, the solution is just going to come out as just a nice, even, steady drip from the needle tip. The more we push or the harder we push, and if we do it intermittently, there can be a bursting effect as we move through the tissues. And if we're pushing really hard and just emptying that cartridge very rapidly, like 30 seconds or less, then we actually create a stream that patients will perceive differently. So kind of going back to our original, learning and the, subtle elements of neurophysiology. Remember that in order for a stimulus to be sent along a nerve axon, that there has to be a great enough pain stimulus to raise it above the firing threshold. So in this case, that burst elevates us up to firing threshold. Streams will elevate us up to firing thresholds. When we're advancing slowly and that drip, there isn't enough stimulus to raise it up and actually fire that axon. The anesthetic at the slow rate is absorbed gradually. It's going to, diffuse into the tissues, move through those fascial spaces, and it doesn't build up pressure within the tissue. We're not getting a tightening or stinging sensation just simply from expansion of tissues and rapid delivery of that stream. Again, that stays below firing thresholds. Slow rate, drop is going to give us that minimum pressure and really comfortable in tissues. The rapid rates create bursts that creates increased localized pressure in the tissue, increases discomfort, and that's going to exceed the sensory pain thresholds, and patients will perceive that. Other thing, to consider in that is the impact of needle gauge. A lot of people are going to say, I use 30 gauge needles because they're going to be more comfortable. A lot of research has been done on that over the years, and in 2006 in particular, this article, Diggle, Deeks, and Pollard really showed that the needle size just is not registered with patients. They don't feel that. Larger gauges, slower rates, however, produce lower fluid pressures, reduce post-injection pain, and reduced edema. Complete opposite of that belief that 30 gauge equals less trauma. So if you have a 30 gauge at 1 milliliter per minute, you're going to have a greater stream forcing out than you're going to have with a 25 or a 27 gauge needle. Just think of it in terms of this is just your garden hose. When it's coming out those slower rates, it can easily flow. It's not restricted. But as soon as we start to decrease that lumen, we increase that pressure. So given the same rate, all 30 gauge needles will create a stronger stream that can be perceived as pain upon injection. Here's another interesting article to take a look at. When we see the name Gow-Gates, we think of George Gow-Gates, we think of the Gow-Gates injection, but there's some other things that they talked about in their research, early on that are worth considering. And one of the points was that there's a relationship between rate and increased hydrostatic pressures. And this can reduce the retention of the local anesthesia. So they looked at a situation where they deposited 2 milliliters of solution at the average location of an inferior alveolar injection, and they deliver that anesthetic, that whole cartridge, in less than 20 seconds. That increased the pressure 32 times. So if they went from a rate of 1 cartridge per minute or slower, compared to emptying a cartridge in less than 20 seconds, it increased the pressure of the drug exiting the needle 32 times. One of the things they actually found in that was also that the anesthetic actually at that rate and pressure can be lost through the capillary walls. Actually is going to be less drug going to the nerve membrane because it's being picked up into the local capillary walls and carried away. And so one of their premises was that it's possible by those rapid injections to actually reduce your success because we're actually aiding the anesthetic escaping away before it fully bathes those neurons. So let's look at the 3 devices that we have readily at hand. Just really quickly, I am going to be talking about all three of the devices. I'm not affiliated directly with any manufacturers. This is not intended to replace a training or manufacturer's instructions. And when you do start working with the devices, be sure that you take time to become familiar with the information for each of the unique devices. So let's look first at the two main parts. There's the drive unit, and then there is the handpiece and the handpiece configurations. The basic drive units all have the same features. It's your power on and off. It's the location where you're going to select the unique flow rate you want for the injections. It's going to have the location of activating the flow and aspiration settings. It is the location of the pressure sensor indicator, and also where you have the ability to retract the piston to reload cartridges. Each of the devices is going to have a place where you can select one of three settings that will coordinate again to our type 1, type 2, and type 3 tissues. And if you look at them, all sort of collectively, this is a general range. So each of them will control the flow for type 1 tissues to approximately 1 minute per cartridge. For type 2 tissues, those less flexible tissues, it's going to control that flow rate to approximately 1/2 cartridge per minute. And in type 3 tissues, that very resistant tissue like periodontal ligaments, it's going to control that flow to a rate of approximately 3 minutes per cartridge. I find that probably the biggest piece on the learning curve was actually moving to using a foot pedal to activate your anesthesia versus your thumb. And although we're really used to rheostats, hygienists are really used to ultrasonics, dentists, all sorts of different, rheostat-driven devices, it takes a little bit of, just a mind switch to move to a foot activation. Good news is that the pedals, are very similar to things we're already used to. And once you, get the calibration of what different choices you have by different pushes on the pedal, people acclimate to this very quickly. But sort of the first, paradigm shift is it's going to be with my foot. Next thing is with the DentaPen, there's actually two different designs. If you look at the little black lever at the head of the device, you can choose which style, whether on the left, you're using more of a syringe grip toggle, or on the right, then you can actually hold the device in a pen grip style. Basic drive units, all three of them have a pressure sensor, which is going to let you know when there's either an overpressure situation or you've properly achieved pressure. So when you look at the image on the left for the wand, when you see those lights go up, that's telling you you're building pressure and we have enough solution of pressure to deliver through a periodontal ligament. The other two devices are generally going to give us an overpressure signal where we need to slow down our delivery to be comfortable and effective in that type of tissue. So here's just, an example of, sort of the benefit of that. And we think of like the adaptive capacity of tissues. Really getting used to looking at blanching. So if you're doing a periodontal ligament injection, that's one of our key visual cues for success is that peripheral blanching. On an AMSA injection, same thing. We're looking for that blanching pattern. We're looking for that diffusion through tissues. And that's, really easy to manage with those slow pressure settings on these devices. So when we look at the handpieces available to us, the top are common metal syringe. I just have a stabilizer cartridge in there. So the orange is not a drug or something you're not aware of. It's just a balancer. But look at the contrast. The CalaJet, the next one down, when all ready to go, it's about the same size and weight as a standard syringe. The one in the middle, the wand, you can see how tiny and fine that is. And just the weight and the balance will be, very light. Then you move into DentaPen, and we have all of our mechanics right there in hand. It's all going to be finger action. You're not going to have an additional rheostat to that. And again, we have two different designs for that toggle situation. And here's just an example of doing a AMSA injection on the left with that trigger style. and then the pen style doing a PSA injection. When we're doing cartridge setup, the CCLAD and the DentaPen have sterilizable plastic sleeves. So you will adapt them to the device. Your cartridge will slide into that sleeve, very similar to how you'll drop a cartridge into the barrel of a metal syringe. And then you use a standard needle on that device. The wand has a very similar plastic cartridge, but it is built onto the delivery tubing, onto that lightweight handpiece, and is part of the entire disposable apparatus. When we look at the needles, for the CCLAD and the DentaPen, you can use any needle you normally use in your office. Whatever you have will screw directly onto those plastic cartridge holders. The wand is going to come in one of 4 styles, the equivalent of a 27 gauge, so your long needle, a 30 gauge short, a 30 gauge extra short, and they also have a universal. One of the things I like about the universal is if I know I'm going to be giving more than one injection for that patient, I can use that universal wand, and then I have on stock a number of my favorite Lurlac needles. So with a universal wand, I can easily switch out for, 2 different or 3 different size needles during a group of injections. And that is, just a nice way to customize your own personal choices. One of the myths to consider is CCLADs are not just for periodontal ligament injections. I know a number of people that first started looking at CCLADs and said, oh, well, I don't give that many PDL injections. I don't think I really need that. So I really want you to shift that, yes, they all give very comfortable periodontal ligament injections. I think they are just magical in giving periodontal ligament injections. However, they are designed to accomplish anything that you normally do in dentistry. And so just as we go around, here's giving an injection with a wand, an AMSA, and then we gave a PSA with the CCLAD coming around clockwise. We have an inferior alveolar with the DentaPen, and then we have a PDL with the DentaPen. These are designed to be all injection systems and can completely replace your manual syringe. So to change that myth, one CCLAD can give all types of injections. So let's just quickly look at the PSA coming around clockwise. A PSA with the wand, a PSA with the CCLAD, and then the bottom 2 is doing a PSA with each of the DentaPen devices. So everything you already know and do about anesthesia is directly transferable to the use of the CCLADs. What changes up is just the relaxation in your hands and the fact that all of that pressures of delivery and aspirations are now being managed by the computer rather than by your functional anatomy. Here's looking at a group of AMSA injections. Again, coming around clockwise, the wand, the CCLAD, and the 2 lowers, the balance that would be with a DentaPen. Inferior alveolar, coming around, again, upper right, clockwise, the wand, the CCLAD, and then each of the 2 DentaPens in the lower images. So the learning curve for the wand. This is something that I had to learn, and I just my little reminder is, don't choke up on the back. Because there's no cartridge as a spacer or piston as a spacer, we need to remember to move our hand further back on the wand to be able to reach across to the opposite, side of the mouth and have the distance to make that contact. As you see in that first picture, if we're holding too close to the needle hub interface, then that has your fingers, completely reaching into their mouth. A unique feature of the wand is its multi-cartridge functionality. This allows you to stay in position with your injection, just have your assistant switch out the cartridge. So I could deliver 2 cartridges for an IA back to back without removing the needle and reinserting the needle. So you actually reduce the trauma in a situation where you know going in that you're going to want multiple cartridges. And then we have the periodontal ligament injections. And here's where CCLADs really, shine. is we have those, we need to be steady in that space. We need to maintain it. We need to keep a fair amount of force to get the solution, moving into that space. And the CCLADs just calibrate all of that. So the intensity it takes in the clinician's hand to deliver these devices is completely supported and modulated by CCLAD devices. Another little tip when you're doing periodontal ligament injections, if you're having a hard time, getting the space, just think probing. It's the same angulation as you would insert a periodontal probe into those spaces. So if you're, kind of thinking this through, or you don't give a lot of PDL injections and want to start giving more, just a really good, thing for practice and setting yourself up is, manipulating the probe to see where those angulations are. It can really help your success. Another unique thing about the wand is because it has that light, flexible plastic handle, you can actually snap it off at different intervals. And I refer to this personally as the stealth technique, is look how small that is. So I can make my approach to the patient with them having no awareness of any apparatus approaching them at all. And I can do this for any infiltrations and pretty much, anything from bicuspid region to bicuspid region, as long as I have enough, intraoral access to those locations. Another thing, just as a little reminder, if you're doing PDLs or nasal palatines, AMSAs, you just keep a little supply of sterile cotton tips available. Then when you go to do those, you can actually keep that cotton tip right near your insertion. You don't need to worry about contaminating your needle, and it'll just absorb any extra fluid right at that insertion site and keep that bitter taste away from the patient. Another thing I love about all of these devices is these are actually mine. And so when I travel for courses or if I'm working in multiple offices, this is literally my devices and literally how they travel. And these are all just basic, standard lunch bags, and they each have just a little bit of padding, but these can easily be, transported if you're doing mobile dentistry, multiple work sites, or even multiple operatories. They all are small enough to be moved around with great ease. And this group of devices literally have crisscrossed the country, several times. How about a little ergonomics? When choosing syringes, one size may not fit all. And for any practitioner out there with a small hand, any students out there just learning your anesthesia with small hands, this to absolutely be true. And if we take a really hard look at our most valuable assets in dentistry, our hands are number one, right up there, with our eyes, in our ability to practice over, the lifetime of a career and have that sustainability throughout a career. One of the things that gets in our way clearly is ergonomics. So dial back a little bit. Remember that phrase, work-related musculoskeletal disorders, also known as cumulative trauma disorders. So let's just, contrast these devices side by side. So first, here's the manual. This is actually my hand. I wear a small to extra small glove, and you can see the balance of the syringe. But in the picture on the right in particular, look at how I'm having to hyperextend my thumb to just get balance, to get to site on the IA, and I haven't even aspirated yet. When you look at all of these devices that we have available to us, conventional syringe on the top, conventional syringes have a substantial weight to them. They have unregulated injection pressures, unregulated aspiration pressures, and they elicit psychological reaction for many patients when they see you approaching with those devices. Where CCLAD devices, on the other hand, are going to, kind of fall to a similar weight or less. So overall, a CalaJet will be fairly similar in weight. The wand is the lightest of the devices, and it actually weighs less than a half ounce, where all of the devices are going to control your injection pressures, control your aspiration pressures, and they just elicit a different psychological reaction because they aren't that classic syringe that many patients, do have an aversion to. Each time we pick up that syringe, remember that we're having to do a series of flexions and extensions, predominantly affecting the joints in our thumb, to aspirate and deposit solution, and we do that repeatedly throughout the day. If you have a small hand, looking at that picture on the left, my hand's on the bottom. And look at how far back I have to pull my thumb to just balance the syringe to get started. Now look at my coworker above me, and they wear a size large glove, and look at how their thumb is actually already forward and how relaxed their fingers are. So there's no hyperextension to just balance. Small hands have hyperextension just to balance, and then add any push-pull to that and that initial aspiration. One of the things that we did is we hooked up some syringes to just a standard trigger pull gauge, and we measured how hard did I have to pull to get that stopper to move in what I would, call the average amount of pressure I need to aspirate. And we did that, a number of times, and then we measured both directions. How hard did I have to push? How hard did I have to pull? The average was 0.7 to 1 pound for me to move that stopper. And that includes moving it forward or moving it back during aspiration. And again, think of this cumulatively through the day. So each sustained flexion and extension, again, is adding up to cumulative trauma. So when we start out in our workday, each injection is going to take about 300 to 500 grams of pressure to move that stopper during an injection. All of the CCLADs, all is going to be managed within that microprocessor, 0 grams of pressure. So coming around with the wand in the upper left, 0 grams of pressure. CCLAD, upper right, 0 grams of pressure. Both of the DentaPens in the lower images, all of that is being managed by the microprocessor, no additional forces on the clinician's hand. So in addition to the conversation about aspiration, just like any device that we use in our office, the same size instruments, the same design of instruments, the same syringes, it's just not one size fits all for everybody working in dentistry today. So I just want to do, a little bit of looking at each of the devices from that perspective of hand size. So these are the two hands that you saw before. The one on the left is my hand, and the one on the right, my coworker's hand. And the arrow will show you from just under my little finger to the saddle of my thumb, and the width of my palm where I would kind of be balancing a syringe. And then here's that same distance on my coworker's hand. And again, I'm a small to extra small glove, and my coworker is a large glove. And that just kind of gives you a bit of balance as we look through these devices. So on the left, again, that was the picture you saw before of balancing a manual syringe. And so here's the saddle of my thumb lined up with my coworker. And again, you can see that's a stretch for me to get my thumb back that far with a fully loaded cartridge. And then here's how much more relaxed my coworker's hand is. Look at the curve, the relaxation of her fingers versus mine stretched all the way out to get a hold of that. And again, I haven't even aspirated yet. Where on the right, look at the relaxation in both hands. This is holding the wand. There's just, less than a half a gram less than a half a gram of weight in that wand hand piece. Because of the shape of it, we can relax our fingers and close at any point. Here's my grasp for most maxillary injections, particularly for a PSA injection. And you can see, here's where it comes off the back of my hand. So I still have about a third of the length of the wand available to move my hand back as needed. And with my coworker, she still has about a quarter. But look at the relaxation in both hands. And then at the point of aspiration, there's no change. Our grasp, just stays relaxed like that throughout the injection. This is looking at the CCLAD. And one thing that some people find if they're working with CCLADs for the first time is the weight of the CCLAD will remind you a lot of the overall weight of your syringe. It would just be like, holding your manual syringe in this pen style. The left here, again, you can see my hand, and just from the edge of the cartridge to where the microprocessor adapts is about the only portion of that I hold. for my injections. But then when you rest it in a larger hand, my coworker, again, she had plenty of distance to hold on to that good balanced relaxation. You can see that in both our hands. There'll be no need to engage the thumb for aspirations. And both of us, if we were like reaching across arch for an IA, we would have plenty of room to move our hand back. If we felt we needed to be, a little bit closer, we could move our fingers, down onto that cartridge holder. Either way, but see, nice balance, and the weight will feel familiar, although you are holding a weight, which is going to, increase ergonomic trauma anyway. Then here's looking at the DentaPen, and this is with the first grip. And when I pick this up and hold it like a, little trigger type syringe, it just fits in my hand. If my hand was any smaller, that might feel like a little bit of a stretch to me. And here's right at the base of where the motor housing is. And so you can see right where it lines up, but you can also see how far back I have to pull my thumb to hold that. So at this point, the activation I'll need to do is pulling back with this index finger on that trigger. But there's nothing I need to pull back on my thumb. I'll just need to balance the weight of the fully contained microprocessor right there to continue. Then here's the same device in my coworker's hands. And what was interesting is her comment was how far she had to close her hand to hold it in this style. And you can see she's, well forward, but her hand is much more relaxed than mine. We both were able to comfortably give injections, but it just was, definitely a different fit for each of us. Then this is the other grasp where you're using with the pen grasp. And then here's your toggle up here. So in this event, it'll just be a press down, and then it rests right in the saddle underneath my thumb. And at this one, we kind of looked at 2 points. Here's the bend of my thumb. Here's the edge of the housing for the battery. Here's my reach to the pen grasp. And then you put it in a larger hand. And what's interesting is Sarah had to pull back to actually activate that trigger. And then you can see here, it's just barely in the palm of her hand. So her observation was she had to kind of think about it a little bit, how to hold it in a larger hand, where when we switched to the CCLAD, that just dropped right in her hand. And I was kind of, working a little bit with a smaller hand. And then when we picked up the wand, it was the same adaptation for both of us. We just, scaled to where it fit, the weight of it, didn't interrupt in that. And so it was, a real quick adaptation to that. So to that question, can old dogs learn new tricks? If the technology is worth exploring, yes. Has perceived value, improved patient experience, improved clinician success, and improved and sustainable techniques. These all provide excellent motivation for trying new approaches. And my favorite one really is looking at that combination of the patient comfort. Remember back to our study, 6 years running, people prefer to receive the injection with the CCLAD. And then improved clinician success and sustainability, that investment in ourselves and protecting the most valuable asset of our hands really adds to that perceived value. So I really, encourage you to explore the CCLADs that are available to us today, and connect with a company and see if you can have an opportunity to look at the devices and experience them firsthand. And they really can change your sustainability within your day and your comfort in your patients. And thank you for joining us. So thank you, everybody, for your time this morning, afternoon, or evening. I'm not quite sure where everybody is. A few questions here that I'd be happy to answer. First one was, can you use any type of needle with the universal wand? They have a Lurlock connector rather than a insertion end. So when we're using that, we have a separate stock of Lurlock designs. And then usually I can get them at least 4 different combinations of length and gauges, but you do have the flexibility of choosing those that you want. And because of the fact that there's no, sharp insertion, and on the base of the wand, there's 2 needle holders. So if I'm switching from a short to a long, I will set both of those needles up at the same time. and I just reach over and then screw it, lift it off, go over, down, and screw it into the next one, and I can continue. So it's a very easy change out, and just anything through your medical supply to have those alternate needles. The next question is, in the wand, how do you clear out the anesthetic in the tubing when sterilizing? They're disposable component. So the tiny bit of residual that may be in there is just thrown out in the waste. So you don't repurpose any of the apparatus for the wand from the cartridge connector, which it connects into your microprocessor base, to the end of your needle and syringe, which flows very nicely into the next question, is how do you dispose of the wand needle? Do you put the whole handpiece needle into the sharps container? No, because it's just all the light tubing and the connector, you can just cut or pull off the tubing right at the needle. So we just dispose the needle itself in the same way we do any other sharps for the pre-connected needles. If it's the Luralock, we just unscrew that. For the universal, then the whole wand goes in the trash. If we are using one of their bonded ones that has the secured closed system, then we'll snap off the needle portion, sharps box, and the rest goes into general waste. The cost of each device, that's always kind of the loaded question. And to be honest, I'm a little bit cautious about trying to keep up, because there's lots of different, show specials, this, that, and the other. They are going to be across a range, so they're not going to be an equal price point, but you are going to be contrasting, the different kinds of, benefits of each machine. So on that one, I'm actually going to, tip that back to your local dealer for what's available to you in those ranges. But I will say, from my perspective, they're not cost prohibitive to practice. And even as a hygienist, I actually own my own device, because that's my investment, in my sustainability for practice. So I think they're a reasonable investment, and to the extent that it is possible to have multiple in an office if you're using them in multiple operatories as well. That was, yeah. And if anything else, like I say, it just takes a little getting used to, but I will kind of end with one thing. Is on Wednesday afternoon, I'm working in a clinic with a student, and they had a patient that just really asked for, can I get numb for this? And the student wasn't quite in the training yet. And so I went to the cupboard, got the wand all set up, and was going to do a PSA and an AMSA injection for this upper left quad for this gentleman. And I got all done with the PSA, and I'm prepping up for the AMSA, and he kind of looks at me funny and goes, "Are you done?" And I said, "Yeah." And he just started laughing, and he says, "No way." And I says, "Yeah, way." And then we went ahead and did the AMSA. And after that, he just goes, "Wow, where did those come from? Where have they been?" And it just was, that moment of experience, kind of like my students had. I want my injections with that device in the future. And I think that's, a real testament to the value to our patients as well. Now, there was one other comment, and actually I am going to respond. One individual said that they were able to actually get a device on eBay. If you get them through, sometimes, that might be alternative sites, it still would be a really good idea to maybe send it in and have it, checked out. You can have them kind of checked and calibrated, making sure you're doing the maintenance on those is really important. And making sure that if you're acquiring one, secondhand, or that you're not 100% sure of which dealer it came through, you want to make sure your O-rings are in good shape and all the functionality of your piston is smooth. And so, really make sure you do the maintenance immediately, and that all of those, working components are in good shape. Again, we have a few more minutes lingering. So if you have any other just curiosities, please feel free to pop them in the questions. 2, are there classes available to learn how to use devices? It's sort of a mix of things. There are pretty much all the companies work with different individuals who are using them in their practices. I do hands-on classes at different conventions and try and have them side by side. One of the things is that keep in mind the injections are the injections, you're just replacing your psychomotor skills with a managed computer microprocessor. And once you get used to, activating that foot pedal, learning the different tones or lights that the device you're working with has, then it's not like relearning injections. It's just learning literally kind of the bells and whistles as you would if you're changing to digital, radiology, digital impressions or those things you needed to learn that piggybacked onto all those transferable skills you already had. And I'll actually be in San Diego in September and Tucson in August, and we'll be doing a little hands-on, if you happen to find yourself in those areas. Also, if you get in touch with some of the companies, they'll actually do webinar trainings. Some of them you can actually have a device come to your office for a trial, and then they'll get on Zoom with you and walk you through. So reaching out to the manufacturers or your local dealer, there are some unique ways people have come together to get those hands-on experiences to you. Next question or comment was that an individual has an STA wand in office, and they also have the Anutra. And says, can these be used together? They're both just syringe opportunities to deliver. So on the Anutra is about buffering, and the Anutra needs its own syringe. If you want to buffer and use the wand, then the option will be that you're going to go to a per cartridge buffering system. Then you can load directly into the wand. So yes, I buffer cartridges, load them into the wand, and successfully incorporate both buffering and CCLAD, which is like really the most optimum way for comfort. But the Nutra is not going to connect and interact. You would have to, otherwise get it back in a cartridge. So not easily integrated to have the computer advantage with the Nutra buffering. And I started the presentation with welcome to the rain in Washington, and we're going to end on sunshine here on the west coast of the US. So good day for all. And if you haven't already, on your way out, you'll have four questions on the quiz for your CE. And so that would be your next step. So again, that looks like all the questions that we had, and thank you for your valuable time. And please, explore CCLADs. They really can make a difference in your day and for all your patients. And have a good week.